Honorable members of the International Conference on Intelligent Systems for Molecular Biology. My name is Yvonne, and I will be presenting on the research topic entitled Predicting the Severity of COVID-19 Infection through the Concentration of Interleukin-6 Cytokine as a Primary Inflammatory Marker. This is our table of contents outlining the general structure of our presentation from background information and literature findings, objectives of study, method of research, discussion, and interpretation of results. Studies reported the presence of cytokine storms in COVID-19 infections, releasing proteins such as interleukin-6, interleukin-1, interleukin-12, and other inflammatory markers. Inhibitors of these markers have alleviated lung tissue damage from the cytokine release syndrome in patients diagnosed with COVID-19. In 2016, Zhao and Yang postulated that a type of cytokine storm contributed to the high mortality rates associated with prior viral epidemics, including the H1N1 Spanish flu, H2N2 Asian influenza, H3N2 Hong Kong influenza, H1N1 pandemic influenza, and the avian flus that occurred between 1997 and 2014, which was caused by several different virus strains H5N1, H7N9, and H10N8. To define a basic relationship in our study, IL-6 plays a crucial role in mediating inflammation. Furthermore, the presence of IL-6 induces the synthesis of CRP. CRP blood test measures the amount of a protein in the blood that signals acute inflammation. As such, CRP tests can be useful in identifying patients with higher IL-6 content. However, with consideration to the effects of inflammatory markers on the severity of COVID-19, researchers have reported associations which vary in strength and direction. Thus, the study aims to compile clinical values of CRP and IL-6 content in patients diagnosed with the virus. A meta-analysis is then performed to analyze a definite relationship between inflammatory markers and severity of COVID-19. To perform meta-analysis, 7 studies with the clinical records and laboratory results of patients diagnosed with COVID-19 were compiled from literature databases including The Lancet, Springer, and European Urology. A prerequisite for the nomination of studies that would be included in our meta-analysis was the presence of individual data. In specific, CRP values pertaining to every patient was necessary to compute variance levels in each study. These values were integral to our computation of weight values using the inverse variance method, in which the weight value is computed with the equation weight value equals 1 over SE squared, where SE refers to the calculated standard error value. Unique values were computed for each study and converted to relative weights using the calculation percentage weight of study A equals weight value of study A over the sum of weight values. Furthermore, we constructed 95% confidence intervals using z-score value of 1.96 for every study. We constructed a clinical index of 7 studies from China, Korea, and United Kingdom. Relative weight values were computed using the inverse variance method as described in the methodology section. A total of 29 males and 22 females were tested, with a mean age of 57.8 years old. Data pertaining to each study was represented in a forest plot, which included average CRP levels in patients, manually constructed confidence intervals, and relative weight values. The data pertained in the forest plot delineates average CRP values of every study along with their respective confidence intervals. Boxes were placed around the respective average values, with their relative sizes representing the sample size of a study. Zhang Zhe's study consists of the largest sample size, indicated by the largest box size, among others. In the study conducted by Sabados B. et al., the data presented does not illustrate a statistically significant result due to its confidence intervals exceeding the line of null effect. In essence, any data point that lies on the left of the null line is statistically insignificant since negative CRP values are unattainable. Following this definition, 5 of the studies present statistically significant results, and 2 depict statistically insignificant results. Additionally, a dotted line is drawn to indicate the effective average CRP value at a value of 57.80 milligrams per liter. Counterparty presents evidence of healthy individuals possessing CRP values of less than 0.3 milligrams per liter. When comparing this quantity with the effective average CRP value presented in the forest plot, a major difference can be observed. Furthermore, every study presents a mean CRP value above this threshold, with only 2 studies presenting lower confidence intervals that achieve healthy CRP values. It is important to note, however, that these 2 studies' confidence intervals surpass the null line, indicative of statistically insignificant results. Thus, when considering the latter, statistically significant studies, the lower confidence intervals present values larger than 0.3 milligrams per liter. Ultimately, meta-analysis presented a definite association between COVID-19 severity and inflammation. In specific, CRP content known to increase in the presence of inflammation was recorded for patients diagnosed with the virus. Greater CRP content was observed in these individuals in comparison with average healthy CRP value. This discrepancy of high levels of CRP content with consideration of the patient's pre-existing conditions paved the way for possibly employing the test as a guideline for differentiating healthy and infected individuals during the current pandemic. Thus, inflammatory tests can function as a preliminary step, such that early monitoring of disease progress is possible, and patients presenting larger contents of CRP can be prioritized in testing. Doing so can optimize the allocation of COVID-19 antibody testing kits in countries like the United States, where a dearth of these resources exist.